Now regarding epidemiology, transmission is there for CMV infection. Close person to person contact is required for transmission. Various modes are there, like oral and respiratory spread is the predominant mode. There may be transplacental route as has been discussed in detail. Blood transfusion, risk of transmission is about 0.1 to 10% per blood unit transfused. Organ transplantation and sexual contact. Reservoir, humans are the only known host for CMV. Virus may be shed in urine, saliva, semen, breast milk and cervical secretions and is carried in circulating white blood cells. Now coming to the lab diagnosis of the disease. CMV produces characteristic perinuclear cytoplasmic inclusions in addition to the usual intranuclear inclusions seen in other herpes viruses. This is known as owl's eye appearance. This virus can be isolated from throat washings and urine by culturing in human fibroblasts, which are the ideal cells. Cytopathic effect is seen after 2 to 3 weeks of incubation. Typical inclusion bodies are seen. There may be multinucleated giant cells and enlargement of infected host cells. Antibody detection is the very important mode of diagnosis. ELISA has been available for detecting serum antibodies. CMV IgM antibodies appear in 1 to 2 weeks after infection and indicates recent or ongoing infection. It drops to below detectable levels within several months. IgG antibodies are produced few days after IgM and persist lifelong. Its presence indicates either a recent or past infection which can be differentiated by performing IgG avidity test. CMV specific PP65 antigen in peripheral blood leukocytes by indirect immunofluorescence test using specific monoclonal antibody has also been used. Nowadays, the molecular methods are more in vogue, that is CMV DNA in blood or body fluids such as CSF can be detected by PCR. Real-time PCR can quantitate the viral load, hence it is the method of choice to monitor the treatment response. As regards drugs, ganciclovir is the drug of choice, but that will be dealt more importantly in the vividly in the pharmacology classes. Both ganciclovir has been used for prophylaxis and preemptive therapy in transplant recipients. CMV immunoglobulin has shown to be effective in preventing congenital infection. Now coming to the Epstein-Barr virus, another virus of this family. It is a member of the gamma subfamily of herpes viridae that causes infectious mononucleosis and is also associated with several human tumors including nasopharyngeal carcinoma and Burkitt's lymphoma. So its importance is somewhere else. Epstein-Barr virus has the different antigens like latent phase antigens. These are synthesized during the period of latency. Early antigens, they are non-structural proteins which help in viral replication. And late antigens, these are structural proteins that form viral capsid and envelope. Coming to the pathogenesis, Epstein-Barr virus is transmitted by oropharyngeal route through infected salivary secretions. The Epstein-Barr virus binds to specific receptors present on B cell, which are also receptors for C3b component of complement. Such receptors are also present on pharyngeal epithelial cells. So in the primary infection, what happens? It occurs in the oropharynx. Epstein-Barr virus replicates in epithelial cells or surface of B lymphocytes of the pharynx and salivary glands. Following entry into the B cells, Epstein-Barr virus directly enters into latent phase without completing the viral replication. Though majority of the infected cells are eliminated, a small number of infected cells do persist for lifetime. Virus spreads from the oropharynx to other sites of the body and is capable of undergoing deactivation later. As regards viral shedding, it continues in oropharyngeal secretions at low levels for weeks to months and serves as a source of infection. In children, primary infections are subclinical, but young adults often develop a condition called an acute infectious mononucleosis. Infected B cells become immortalized by the virus and synthesize large number of variety of immunoglobulins. Many of those are autoantibodies. In response to this, the bystander CD8 lymphocytes are stimulated and appear atypical. Now coming to the clinical manifestations. First and foremost is infectious mononucleosis. It is also called kissing disease because it is transmitted through salivary contact or glandular disease. Young adults are mostly affected. Infectious mononucleosis is characterized by headache, fever, pharyngitis, lymphadenopathy, hepatosplenomegaly, and rashes, and atypical lymphocytosis. Epstein-Barr virus associated malignancies are very, very important to know. The first and foremost is Burkitt's lymphoma. It is a tumor of the jaw seen in children and young adults. It is associated with 90% of African and 20% of non-African cases of Burkitt's lymphoma. Most of the cases have pre-existing mutation. Falciparum malaria may impair host CMI and stimulate Epstein-Barr virus infected B cells. Next comes nasopharyngeal carcinoma. It is seen among Chinese people who have history of intake of salted fish. Then comes Hodgkin's lymphoma. It is specially in mixed cellularity type and DNA is found in Reed Sternberg cells in at least 50% of cases of Hodgkin's lymphoma. And in non-Hodgkin's lymphoma, all CNS non-Hodgkin's lymphomas and 50% of systemic non-Hodgkin's lymphomas are Epstein-Barr virus DNA or antibody positive. So there are so many malignant conditions associated with the virus. If we come to the mechanism of this oncogenesis, you must remember that persistent Epstein-Barr virus infection can induce malignant transformation of infected B cells and epithelial cells by expressing latent Epstein-Barr virus antigens such as LMP and EBNA. Oncogenicity is kept under control by host immune response by producing anti-LM1 antibodies. Hence, oncogenicity is markedly enhanced in immunocompromised individuals. The other conditions that are associated with Epstein-Barr virus is lymphoproliferative disorders seen among immunodeficient patients and oral hairy leukoplakia. This is a wart-like growth of epithelial cells of the tongue developed in some HIV-infected patients and transplant recipients. Epidemiology. Epstein-Barr virus is worldwide in distribution. Infections are most common in early adulthood with a second peak during late adolescence. However, infectious mononucleosis is common among young adults of developed countries. It is common in all parts of the world with more than 90% of adults being seropositive and develop antibodies to Epstein-Barr virus infection. Coming to the lab diagnosis, heterophil agglutination test or Paul Bunel test is a very important test to diagnose Epstein-Barr virus infection. It is a tube agglutination test that uses 3 part bases to detect heterophil antibodies in patient serum. Agglutination titer of more than 256 is considered as significant